Wonderful. All right, good afternoon, everyone. Thank you for the opportunity to present today. My name is Steve Scully, and I'm the founder and CEO of Thaddeus Medical Systems. And we make active cooling and heating for the cold chain in order to improve patient outcomes. Okay, so as an MD Ph.D., I started in the clinic as a pediatric resident and wanted to better understand the molecular and laboratory medicine. And so got my Ph.D. in molecular cell biology and then moved to Mayo Clinic in Rochester, Minnesota, where I'm currently located. While at Mayo Clinic, I was in the neuroimmunology lab and learned about pre-analyticals that affect the immunology lab. So this is something that I wanted to dive deeper into because I was greatly concerned about the impact on patient care and how those pre-analytical errors for clinical pathologists affects patient outcomes. So as we know, in 2010, it was one of the citations about medical errors put it at about 100,000 deaths every year and 1 million incidents for patients being harmed. And excuse me, and you know, nobody goes into medicine with the idea that they're going to ever harm a patient, but we're all human and we're not in a perfect system. 60% up to 70% of medical decisions are based on a clinical lab test. And there are about 1 billion blood draws happening every year. And depending on the institution, up to 5% of the errors that come through the lab can have a pre-analytical issue. And so what I mean by pre-analytics is before the sample is even run on an instrument, things that can happen are temperature excursions. It can be mislabeled. It can be inappropriately stored, exposed to a lot of shock and vibration, et cetera. And so the pre-analytical phase is the most important phase, in my opinion, of trying to eradicate medical errors because it's where the majority of the errors happen. So we're focused on extreme heat, extreme freezing, and drops and shocks to patient specimens. And again, this is blood from a patient, but if you look at it holistically, this is really a patient that we're treating. It's a representative sample of the current state of the patient. And it has tremendous impacts as we move forward into precision medicine. So liquid biopsies, it becomes very important because biology is very complex, very messy, inconsistent, and can be unexpected. And as we take human specimens and use those for analysis of the genome, the transcriptome, the proteome, metabolome, the microbiome, a lot of pre-analytical variables affect these tests. Carolyn Compton is one. She's a cheerleader for pre-analytical issues in the precision pathology space. And she focuses more on genomics, but as proteomics and gene expression becomes more prominent, those types of samples are extremely liable to freeze-thaw cycles. And so that has impact not only on the diagnosis of patients, but on the therapeutics and the therapeutic plan downstream. There's about 10,000 types of clinical lab tests, and a lot of these, as I mentioned, depend on pre-analytical errors, and the protocols that are established for these types of tests need to be followed very closely. And this is only going to get worse because medicine, as we know, is changing rapidly. A lot more happening at the home, a lot more hospital avoidance because of post-COVID and antimicrobial resistance, a lot of remote monitoring, telemedicine, home infusion opportunities. It's convenient for the patient. It's cheaper for the patient. And 20% of the underserved population in the country is rural and remote based and doesn't have good access to a hospital. So we are coming to market with a device that can essentially control the temperature for a blood draw, track it, provide any insights into its risk for a pre-analytical error. In addition, we have an active cooler that provides real-time alerts, precise temperature control at various levels, frozen, refrigerated, room temperature, and is highly reusable and cost competitive with existing solutions. So the smart sleeve that I showed just a minute ago and this cooler work in conjunction, so there's a very good chain of custody and inventory management for samples that are being procured from the home, and also for therapeutics that are being sent to the home that are temperature sensitive. So why is this something that's important right now? We have an evolving demand for cell gene therapy, medicine at the home. Our costs have come down significantly, better for the environment. Our patents have been issued, and we have a great team of SMEs. So our revenue model is to sell the sleeve for under $100 per item, and lease the cooler for under $200 a month. And we have subscription tiers for the data. The market for the cold chain is very big. It's 85 billion right now. That constitutes both packaging and monitoring. For the US and Canada, the serviceable available market is about 50 billion, so 65% of that. And our target market is 5 billion. Our competition right now is the status quo, which is styrofoam and ice, or passive phase change materials. But there are a few active solutions out there, but they use a different type of technology. They use Peltier or thermoelectric technology, which is prone to not doing well outside and failure. So our active compressor has been military spec'd and is extremely reliable and durable, and lasts in very extreme temperature environments. All our patents have been filed and issued with the exception of one. We're designed for high throughput manufacturing in the United States here in Minnesota. Our design is complete. Our assembly work cells defined. Our supply chain has been established. We have a great, I have a great co-founder, Russ Sanders. He's a seasoned global innovator leader with broad experience in the electronic space for heavy duty industrial, military, and aerospace industries. He comes from Thermo King as a master inventor. We have a great board of advisors made up of a pediatrician, VP at McKesson, a retired BARDA exec, associate chair of pathology, and a thermal engineer. As we go to market, we aim to exceed these expectations with 20,000 units in the field, made in 5 years out, and generate a significant amount of revenue within 5 years. Right now, we are in a seed funding and raising $500K to get inventory and get paid pilots. And with that, thank you very much for your time. Take questions.
Thank you, Steve. Great presentation. Let's see. Let's go with Jay.
Well, since you wrapped up early, I'll ask a couple questions.
Yeah.
One, I'll get the questions out and you can answer them in the order you want. Curious to know more in more detail what's in between now and first shipments in 2025. I loved your point. I think you could make it way faster, by the way. We're not good at this. I love that one slide. It was about 5 or 6 in. You could simply say, we're not good at this and we're about to get worse at it now that more stuff is being done at home. It's just that, like VCs in particular, we love to see where the hockey puck is going. And as bad as we are today, 3 to 5 years from now, if we don't get better, we're going to get worse.
Well said.
And then the other question is, I'm really keen to better understand. You said revenue model, but you didn't really explain it. Like I'm talking more, let's zoom out, and what's the business model? Who's gonna pay for this? What is the relationship between, I saw like Mr. McKesson as one of your advisors. What's the relationship between the clinic, the labs, the insurance company, the McKessons of the world? How is all the economics gonna flow through the system? Because what I don't see is a doctor's office necessarily paying for this.
Exactly.
But I'd love to get more into the weeds around how the business model will work.
Sure. So between now and 2025, we're fundraising to get inventory made for paid pilots. The customers at the other end are going to be clinical labs, clinical pathology labs, and medical couriers, and home health groups that are going to pick up these samples and deliver temperature sensitive therapeutics. And they're going to, and so who's going to pay exactly? It's still not clear to me whether it's going to be insurance companies or the hospital systems that want to prevent these types of errors from happening. There is a huge problem there. I just got off the phone with one of our advisors the pathologist, and he's mentioning within the last 2 weeks, they've had a number of these incidents with the hot temperatures up in Boston. And so they're losing opportunities to effectively and timely treat patients. Hopefully that was for my 10
That was
minutes.
just that's just your 10 minutes. You can keep
All right.
going.
Yeah, that was the 10 minutes.
All right. So
Continue.
I think I kind of addressed most of those points,
Yeah.
Jay.
Thank you. Thank you, Steve.
Yeah. My turn, Uli?
Yeah.
Okay. So I'm going to take a different approach on the questions, and I'm going to play the clinician investor and focus on the clinical side of this, because the upside of it is, which you pointed out well in your presentation, is the transition that we're about to make. And it's going to happen a lot faster than people realize, of going from the hospital and clinic setting to the point of care. Okay. And whether that point of care is a clinician's office or somebody's house or a senior living facility or whatever, that's where we're going. Okay. The other part that I will say is and one of the reasons for the increase in the slope of the curve of collection is that we're about to enter the genomic phase. Okay. And genomics is going to play a huge part in precision medicine moving forward. So where do we collect those samples? And you can see in my name, I'm a dentist too, although my D is missing, it's at least on mine. And I believe that, like, those places, the dental offices where people go more often, are likely the places of collection of the saliva, of the blood, of whatever. But it brings up several questions about what effect this has on the cost of the system. Okay. Mm-hmm. So if you've now got to go to the point of care, as you pointed out, you need a system that either delivers someone that delivers an individual that can collect. Okay. So if it's blood, they may have to draw the blood. Okay. Or does the location have that in place already? 2, they have to be able to storage it and transport it to wherever it has to go. Okay. So that's the second part of it. That's cost added to the system, as opposed to now where the patient goes to that place. And then, just the whole concept of the sample maintenance, because there is, I wouldn't say liability, but there are issues there, and you're addressing that. As a very quick aside, I have to say that yesterday I had some testosterone delivered to my house. Okay, so looking at the market of not just collecting samples, but medications, intravenous delivered medications at the point of care. They delivered it to my house in this manner. I have a gate at the front of my house. They stuck it in a box. They crushed it, pushed it under my gate, and left it out in 96-degree weather. Okay, and it's an IV solution, which, right? So I understand, I was livid, and I understand how important this is, especially when you extrapolate it to those things. But you really got to focus in on, and what we're going to want to hear from a VC perspective is, how does this, I understand it improves the efficiency of the system, but who's going to pay for all of this to get that sample from the patient to where it needs to go and keep it protected in the middle of global warming, as you point out?
Mm-hmm. So I think the value that we're bringing is significant, and that our costs are competitive with what's being done right now. So no matter what, you're going to have to pay a nurse to draw blood at the patient's home. You're going to have to transport it. You're going to have a lab that can provide storage, appropriate temperatures and such. What we're asking is that for a few dollars a day, essentially, you get a system that is not only going to provide extreme temperature support and tracking, and be able to predict as well, like if you're going to have one of these pre-analytical errors. The workflow that's involved for the clinical pathologist right now is insane, and it's only going to get worse as these. I mean, 5% of the time, 5% of their workflow, 5% of the samples that they are getting up to that are having pre-analytical issues. They have to stop. They have to call the patient, make sure it's not a risk to their health if it's a hyperkalemia event. So it's burning up a lot of salary or dollars to pay the pathologist for these types of inconveniences. So I think the hospitals will be on board if they can see the whole picture.
Although I will tell you again, talking as an anesthesiologist, and Uli will probably allude to this from the ER perspective. If I had $1 for every time I had to make a phone call from labor and delivery or the OR to pathology, screaming at them because we were up to our knees in blood and we needed the blood, and we sent down the sample. And from the time that it went from the OR to the lab, it either clotted or it got dropped or whatever. So, it even happens when there's only 100 feet between the two places. So, those issues will not disappear. And as a matter of fact, the complexity of the delivery system will probably make more issues. But I truly understand what, it's going to happen, whether we like it or not. So it has to be done safely and securely. And that's what I like about what you're doing.
All right. Thanks, Gary. Thanks, Steve. Thanks, Jay.
welcome.
Let's
Thank you
move
for the
on to our next